Okay, this is a brief presentation over the head trauma content. So head injuries are any trauma that can happen to the skull, scalp, or brain. It's going to be a sudden force to the head from either falling or from a moving object hitting the head. There is a fairly high incidence, with about 275,000 being hospitalized annually, and about 20% of these hospitalized patients die. However, the numbers aren't completely accurate because some minor injuries, patients may not come to the hospital, and then some patients where it's a traumatic, serious head trauma, these patients are dying at the scene. So the most common cause, obviously, for head trauma is motor vehicle accidents. Falls is second, most commonly in our elderly and maybe even our younger population, infants, toddlers. So death with head injury can occur at 3 points in the time after the injury, either immediately, usually related to hemorrhage, shock, a traumatic open skull injury with herniation immediately, or within 2 hours, and then usually 3 weeks later, and usually with that death, there's going to be multi-system failure. There's going to be more, other than just the head trauma, there's going to be more events that are associated with it that have led to the death. So factors that predict poor outcome: age, and then hypotension, hypoxia, and hypercapnia. So these are important components when we're thinking about intracranial pressure. They all have the potential to alter perfusion pressure, and they all have the potential to increase intracranial pressure. So when we talk about intracranial pressure, to make a little bit more sense, but some of those factors then, if their pressure is low, we're going to have a hard time perfusing the brain. So we can actually create a more extensive damage, injury to the surrounding tissues. And then hypoxia, hypercapnia, we always want to keep our patients in a normal pH. We don't want them to be hypoxic, and we don't want them to be hypercapnic or even acidotic, because it can actually alter intracranial pressure. So anything of an ICP greater than 20 millimeters of mercury, this usually is a fairly ominous sign where these patients are going to herniate. So decreased level of consciousness on presentation or immediately right after the injury. Those are all factors that predict poor outcomes in your patients. So scalp lacerations, they might just be an external head trauma, and they're the most common, and they're just kind of limited to the superficial area. The problem with scalp lacerations is that because your scalp is highly vascularized, there's a lot of bleeding. Even a minimal damage, a scalp laceration, could cause a lot of blood loss, which makes it seem like more of an injury than it really is. So major complications, obviously, blood loss and infection. So with a scalp laceration, though, you have to be careful because there could be an existing skull line fracture, like maybe a hairline or linear fracture underneath. And so you have to be cognizant of a patient with a scalp laceration. So you might be palpating the area and around, and you want to consider a CAT scan of the head depending on some of their presenting symptom signs and the mechanism of injury. So skull fractures, there's different types of skull fractures. Either it's closed or open. So is there a break in the skin? Linear, this is where there's going to be a break, but there's still continuity of bone. So it could be considered kind of like a hairline. Is it simple? So is it without communicating lacerations? Community is linear fracture, however, but there's a lot of fragments. And then depressed, so the skull is actually going to be depressed inward onto the cerebrum. So there's an inward indentation of the skull. And a compound is going to be probably more severe. It's going to be open, and it's going to be depressed as well. But there's going to be a communicating pathway between the external environment and the cranial cavity. So some of the complications from skull fractures, obviously infection, we've got an open route. Hematomas, if the skull fractures are compound and they're depressed. We worry about bleeding and obviously existing tissue damage, ischemia, necrosis to the underlying tissues. So this picture just shows kind of a linear, and then you've got it's non-depressed, and then you've got the comminuted fragments of the skull right here, broken into segments or fragments. And this is going to be a depressed, so where it's caving in kind of under the cerebrum, and this is compound, where it's open from the environment to the cranial cavity. And so some of your depressed skull fractures, or your compound, these patients are going to have the depressed skull fracture actually repaired. So a lot of them will have maybe hematomas that are associated with it, and those are going to have to be evacuated as well. So if you want to talk about skull fractures, we've got different locations, so different locations are going to have different manifestations. So your frontal and your orbital fractures. So this is where the front of the brain is going to be exposed to the frontal air sinus. So a lot of the manifestations that you'll see with the frontal is rhinorrhea. So you might have leakage of cerebral spinal fluid from your nasal cavity. It's very clear that it has a high glucose content. And so if you get air into the sinus cavity, it's called the pneumocranium, or kind of within your cranial cavity. Pneumocranium. So with the orbital manifestations, these patients can have the periorbital edema, the periorbital ecchymosis, or the bruising around the eyes that's referred to as raccoon's eyes. And then in some significant orbital fractures, you can have optic nerve injury and vision loss. So with the temporal manifestations, if you got a temporal skull fracture, these patients can sometimes have a boggy temporal muscle if you're kind of palpating behind the ear in the temporal location. If these patients have got some accumulation of blood, they might have a boggy temporal muscle. Autouria. Sometimes these patients are going to have leakage of cerebral spinal fluid from their ear. And again, the same characteristics of cerebral spinal fluid. It's going to be clear, and it's going to have a high glucose tolerance. And they're also going to have post-auricular ecchymosis, so this is referred to as battle signs. So there's going to be a lot of bruising behind the ears. So your parietal manifestations, these patients can be deaf, facial paralysis, bulging of the tympanic membrane, and they actually might have bleeding behind the tympanic membrane. Okay, so this is hemotympanum. And then they're also going to have battle signs as well, so that post-auricular ecchymosis. And then they could have loss of taste. So I don't know if this is affecting cranial nerve 7, the facial nerve. So your basilar skull fracture is the most, not necessarily the most common skull fracture, but I think it's the most characteristic of all skull fractures that you need to be aware of. Okay? It's a linear fracture that occurs when the fracture involves the base of the skull. Okay? So some of the characteristic manifestations with the base of the skull fracture is periorbital edema and ecchymosis. So they're going to have raccoon's eyes. And then they're also at risk for having, the battle signs, the post-auricular ecchymosis. So the bruising and the ecchymosis behind the ear. These patients are also at risk for rhinorrhea and autouria, so actually leakage of cerebral spinal fluid from their nose and from their ear. And this has to do with the laceration of the dura. So some of your biggest complications with skull fractures is infection, and that's an important component to remember with basilar skull fractures. So typically it's going to be a linear fracture, and it's at the base of the skull, and it's going to be associated with a tear in the dura layer, and as a result we're going to see leakages of cerebral spinal fluid where it's not supposed to be. So from our nose, autouria, from our ears, autouria, from our nose, rhinorrhea, battle signs, raccoon's eyes. And if they have problems with the ineffective cranial nerve 8, They can also start to have some tinnitus or ringing in the ears and hearing loss. The basilar skull fracture, sometimes even if they don't have rhinorrhea, they also might have a lot of postnasal drip associated. So it could be the leakage of cerebral spinal fluid leaking back. So we said high risk for meningitis infection. So these patients, you're always going to be monitoring them for elevations in temperature as well. And so sometimes there's some thoughts about, do these patients need antibiotics? So we said high glucose content in cerebral spinal fluid. So how do we test it? So we can test it with a Destro strip, a glucose strip. So if it's positive for glucose, it could be cerebral spinal fluid. However, if there's blood in the sample, which we know a lot of times there can be if there's associated trauma, it's considered an unreliable sample. But if we actually collect some cerebral spinal fluid on a gauze pad or some sort of cloth, there's pretty characteristic pooling of blood in the center, and there's always going to be this like halo yellow sign or ring around the centered blood that's kind of coagulated. So you can kind of see right here the cerebral spinal fluid where the leakage or the kind of clear yellowed is on the end and the blood is in the center. So further types of head injuries can be characterized as being diffuse or generalized, widespread, or being more focal or localized. And then we said the GCS, we're always evaluating that with anybody who comes in with head injuries because we're evaluating their level of consciousness. So, head injuries that have a GCS of somewhere between 13 to 15 are very minor. When they start to get to 9 to 12, moderate. And then we know anything that's less than 8, we always anticipate protecting their airway, intubating these patients, putting them on the ventilator. Anything less than 6 or 7, you're concerned about really being in a coma, level of consciousness significantly depressed. So concussion, so this is kind of considered a diffuse injury, very generalized. It's not always localized. So it's considered a minor head injury. So with a concussion, there can be a brief disruption in level consciousness, or they might not fully lose consciousness. Okay, so there's a disruption of neural activity. And if they do lose consciousness, it's going to be temporary. It's going to be just for minutes. So a lot of the manifestations you see with a concussion, this is from a motor vehicle accident, fall, or somebody has a sports injury, they could have retrograde amnesia. Okay, so they forgot the event. They forgot the inciting event that led to their head injury. Headaches, of short headaches and retrograde amnesia, so the biggest two manifestations of concussion. So usually if these patients have not lost consciousness or minimal short duration of level of consciousness altered, they may send these patients home. Okay, so they may discharge them home with a caregiver, making sure they're being closely monitored. So post-concussion syndrome, this can happen 2 weeks to 2 months after the injury. So these patients can have a persistent headache, maybe a little bit of lethargy, and some definitely personality and behavior changes. So sometimes these patients may be a little bit more cautious, a little bit more impulsive, just very quick emotional responses, so a change. Have problems with their memory, and maybe some changes in their intellectual ability temporarily. So some of the teaching that we need to do, especially if we send these patients home immediately after a concussion where they don't need to be monitored in the hospital, is we need to make sure the family and the patient is aware any kind of worsening headache or stiff neck could indicate true bleeding, increasing intracranial pressure from the concussion. Increased drowsiness, obviously that means these patients, their GCS is decreasing, their intracranial pressure is probably rising. Which is a big increasing drowsiness, lethargy after head trauma is usually an ominous sign. Seizures, any kind of vision and motor problems, which just means that some of your cranial nerves, some of your motor motor activity is being compromised by the compression within your brain. And then your heart rate less than 60. So this can be that the medulla is being compromised. And it's also a sign of rising intracranial pressure from, I guess, that medulla being, or that brainstem being compressed. So worrying about your heart rate being low. Those are all things that you're concerned about reaching out to the healthcare provider immediately if a patient has had a post-concussion. So these patients probably should not be alone. They should be abstaining from any type of alcohol or sedating medications that can increase their drowsiness and kind of make it difficult to assess their level of consciousness or whether they're truly becoming lethargic. So some of your diphenhydramine, Benadryl, any types of benzodiazepines. So no driving, taking hot baths or playing sports, or maybe even operating, guns, any kind of weapons. So we need to be careful with these patients right after a concussion or if they have post-concussion syndrome. The last thing we want to do is have a kind of a second impact syndrome where they develop another head injury with the initial one. So lacerations, so a little bit different than scalp lacerations. So this is going to be tearing of the brain tissue, which can actually be a problem because the brain tissue is not able to be surgically repaired. It can happen with depressed and open skull fractures or with penetrating injuries. So a couple things that we need to be monitoring for is infection and rising ICP. So these patients are going to need antibiotics, and we're always going to be monitoring them for bleeding associated with the lacerations. So some of your manifestations are pretty general to head trauma in itself and rising ICP. Unconsciousness. There might be some contralateral hemiplegia, so contralateral to the affected side of the brain, to the affected extremity. There could be dilated pupil on the affected side or on the side of the brain where it's been affected, so ipsilateral dilation. So your pupil sizes are going to be unequal. So contusion, so just the bruising of the brain tissue. So this can be associated with a closed head trauma, and this is much more damaging than a concussion. So it can lead to hemorrhage, rising ICP, infarction, necrosis. And contusions can rebleed. So some of the same things that we were looking at with brain lacerations, we're looking at level of consciousness, monitoring for seizures. In any head trauma, we're concerned about if these patients come into the hospital and they've got aspirin and antiplatelet or any medication that causes anticoagulation on their MAR, their medication record. If they come in with some sort of head trauma, we're concerned. Their increased risk for bleeding. So some of the coupe contra coupe injuries that can happen with even concussions or with contusions is where they can have a site of primary impact and then a site of secondary impact. So it can happen in these coupe contra coupe injuries where their head goes back and forth. So sometimes the secondary impact is even a little bit more damaging than the first. So we've got two areas of kind of swelling and bleeding that can compress our tissue. So these patients are significant risk for rising ICP with herniation. So epidural hematomas, probably your most serious and catastrophic hematomas. There's going to be bleeding between the dura and the inner surface of the cavities. It's considered a neuroemergency because it's usually arterial in nature, and so it's going to be really rapid in flow. So these patients who have an epidural hematoma or an epidural bleed, it's usually going to be a kind of clip of the meningeal artery. So it's initial period of unconsciousness, and then they may briefly wake up where they talk, where they're a little lucid, and then they might go out again, and then they will never wake up. Okay, there's a really high mortality of epidural hematomas. So there's an immediate deterioration. So when they're awake, they might complain of headache, nausea, vomiting, focal findings around the localized area where the head trauma actually occurred. And in order to minimize the mortality, it's going to require rapid evacuation, or it's going to very quickly lead to rising ICP herniation. So here's just kind of a picture of where the epidural hematoma is in comparison to some of the subdural hematomas, or the subarachnoids. So it's just a picture of where there's actually a craniotomy being done, so where they can actually go in, remove the hematoma, evacuate the blood. So subdural hematomas, it's going to be bleeding between the dura mater and the arachnoid. The most common source is the veins that drain the brain surface into the sagittal sinus. It can be arterial, but we usually associate arterial bleeds with epidural hematomas. So with subdurals, we think of veins. So the blood is going to accumulate at a much slower pace. So these patients have hopefully decreased mortality from somebody with an epidural hematoma. So acute subdural, within 24 to 48 hours after the injury, these patients are going to present with manifestations of rising ICP. And so the size as well, like we said, the size of the hematoma determines that ICP and the swelling, and it's going to determine those manifestations. So we said decreased level of consciousness. It's always the first manifestation we see in patients who have increasing ICP. Headache, ipsilateral pupil dilation, and fixed if severe. So if on the side of the brain where there's the injury, where there's the hematoma, we're going to see ipsilateral pupil dilation, and it can be fixed. So just like with the epidural hematoma, these patients are going to need rapid evacuation of the hematoma via craniotomy. So the subacute subdural hematoma, usually within 2 to 14 days of the injury. So it may appear to enlarge over time. And obviously the manifestations are going to become more pronounced as the hematoma grows and becomes larger. So some of the same manifestations that we saw with the acute subdural hematoma. It's just going to take a little bit longer to grow, and so we're going to see it 2 to 14 days versus the 24 to 48 hours. So a chronic subdural hematoma. These are where the hematoma can develop weeks or months after the injury. And so our most common population with a chronic subdural hematoma is our older patients and alcoholics. So these patients may have fallen, been involved in some sort of traumatic injury, and they don't remember the event. Okay. And some of the reasons with the older adults and the alcoholics, it's like the space within their cranial cavity and with their dura have kind of changed related to either age or related to the effects of alcoholism. And as a result, the area where the bleeding is occurring has a much larger capacity for blood accumulation. So that's sometimes why it will be weeks to months after the injury, because the hematoma has had a larger space to grow. So when they do actually present, because it has been so long since the event and they've forgotten, they might be misdiagnosed. Okay, so they might be classified as maybe having dementia, or they might think they're having a TIA or a stroke. So some of the diagnostic studies we're going to consider with any types of head trauma, CAT scan, right, immediate. MRI is more sensitive than the CAT scan, we know. It's going to see more slight damage, more slight injuries, but it also takes a little bit longer, and there's a lot more exclusion criteria to actually getting an MRI. Some implants, pacemakers, things like that. So CT is kind of your first line defense with a head injury. And then we can consider doing transcranial Doppler studies to assess blood flow. And then we're always going to consider doing x-rays if there's additional traumas associated with the MVA or the fall. GCS, we said we're always going to be doing that to assess level of consciousness on presentation and throughout. It can guide our treatment. It can let us know if patients are deteriorating or if they're improving. And so labs, CBC, assessing their hemodynamic stability, BAM, looking at their renal function, electrolytes, especially if this patient has alcoholism, and then we're looking at toxicology reports, especially if this is associated with recreational drug activity. So what are we going to do for these patients on presentation? Same way that we take care of these patients with stroke, spinal cord, patent airway, assessing their ability to protect their airway. Are they awake enough? Do they have a gag reflex? We're always going to stabilize their cervical spine with head injuries because we're always attempting to prevent or identify early to prevent secondary injuries to the spine if they've got a cervical injury, which makes sense if they've had some head trauma. Oxygen, adequate IV access, and a good location. And if these patients have a GCS less than 8, most often they're going to be intubated and put on the mechanical ventilator. We want to make sure that we control external bleeding, and then make sure we're removing the patient's clothing if it's appropriate, because sometimes if it's wet, it has a lot of blood on it, it could actually lead to hypothermia. So emergency treatment, making sure these patients are warm, especially if they do have an associated spinal cord injury with them. Above T5, T6, we are suspecting neurogenic shock, right? So their inability to maintain body temperature below the level of injury, okay? So they can't conserve, they can't get rid of heat. So we need to do that for them, okay? So monitoring their temperature, making sure they're warm. Ongoing monitoring, vital signs, level of consciousness with their GCS, O2 saturations, always looking at the monitor, ECGs, and their pupils. We talked about intubation. When we need to assume a neck injury, and we need to be careful administering fluids. We want to maintain their hemodynamic status, but it's not necessary to give them too much fluids. Okay, this isn't shock, but we do worry about increasing their cerebral edema and rising ICP. So we need to be keep these patients euvolemic, normovolemic. So some other things that we can do for preventing the secondary injury is managing the cerebral edema, increasing ICP. That's going to just not only decrease our cerebral perfusion pressure, making the damage and the necrosis worse, it also can lead to herniation. So timely diagnosis, surgery if necessary. So these patients can get a very quick burr hole to kind of decompress and help with that rising ICP. They can get a craniotomy or they can do a craniectomy. So sometimes with the skull fractures or with any types of head trauma, they can do conservative treatment. But if they need to, if there's a depressed fracture, they're going to have to go in and do surgery to actually kind of remove those fragmented pieces and to inspect to see if there's underlying hematoma, blood accumulation. So with the subdural and the epidural hematomas, there's always going to have to be a surgical evacuation of the hematoma. And like we said, we can do this through very quick burr holes, a craniotomy, or in extreme cases where they actually can't replace some of the fragments of the skull fracture, they'd have to do a craniectomy where they leave a piece of the skull off for a period of time until the swelling subsides. So the next picture is going to be a picture of a craniotomy where they actually go in to create a bone flap where they pull it up, take care of what they need to, and then they're going to put the bone flap back down, screw it into plates, screw it back into plates, and then there's going to be drains to alleviate the pressure. So care of the patient with a craniotomy. Their hair is going to be shaved, right, for better visualization, for in a more aseptic, sterile field. Our goal after the care of a patient with craniotomy is maintaining their ICP. So even though the bleeding the source of the injury has been minimized, has been taken care of, we still don't want to increase their ICP with the cerebral edema that has happened, the normal swelling after surgery. So frequent neuro exams. Closely monitor their intake and output. So we said we want to maintain optimal perfusion to their organs, but we don't want to be giving them too much fluid. Closely monitoring their electrolytes. Anybody who has head trauma is always at risk for either diabetes insipidus or SIADH. Okay. So these patients can have some problems with their urine output and also with their electrolyte imbalances. So we're always anticipating monitoring for that. Minimizing pain and nausea and vomiting. And so some of the medications we use with those for pain and nausea and vomiting can affect the patient's level of consciousness. So we need to be cognizant of the medications we're using, especially if we are concerned about adverse side effects. And we're always monitoring for infections. Okay, so these patients, just with any other surgical incision, antibiotics before for a period of after. And we're always attempting to minimize vasospasms. Another reason we're making sure these patients' blood pressure is not getting too low, because we don't want to induce any more necrosis, edema. So maintaining their blood pressure optimally. So some of the existing assessment data, with head traumas, like we said, the mechanism of injury, where did it occur, their medication list, what kinds of medications are they on that could actually impact their bleeding, their edema, or their recovery. Are they any on herbals, long-term steroids, okay? Headache, what type of headache? When did it start? Is it getting worse? Do they have any other neurologic deficits, aphasia, decreasing level of consciousness, nausea and vomiting? That's projectile, and that doesn't necessarily associate the nausea. Some of these patients can have projectile vomiting that's not associated with nausea. And if we see clear leakage from the patient's ear, nose, is it cerebrospinal fluid? What do we need to do to assess it? If they've got impaired gag reflex, if they're unable to protect their airway, it's a problem. They're at risk for aspiration. Pupil dysfunction. Are the pupils equal, round, reactive to light, and is there a positive consensual response? And posturing is a late sign of ICP, and usually it's an indication of herniation. And then Cushing's triad. So as patients' ICP starts to rise and their cerebral perfusion pressure starts to decrease because of this increasing intracranial pressure that's compressing the brain, we're often going to see a rising systolic blood pressure. It's the body's ability to try and compensate or kind of override that ICP to maintain cerebral perfusion pressure. When the systolic blood pressure rises, though, we're going to see a widened pulse pressure. And we're also going to see a drop in their pulse and a drop in their respiratory rate. This is referred to as Cushing's triad, and it's an indication that ICP is rising. So it's a fairly ominous sign. So some of our nursing diagnoses, right? Risk for ineffective cerebral perfusion, hyperthermia if the hypothalamus has been infected, right? If it's inflamed, irritated, impaired physical mobility, anxiety. So our overall goals with any patient who has head trauma is to maintain oxygen and perfusion to the cerebrum. We want to make sure these patients' body temperature stays normal. Okay? Control their pain and their discomfort. We want them to be free of infection. We said a lot of our skull fractures or any kind of open head traumas always at risk for infection. So we're always monitoring for localized signs and symptoms of infection and systemic. Adequate nutrition early. And we want to maximize their cognitive, motor, and sensory function. So from a health promotion standpoint, we talked about the patients that are at high risk for head trauma. So if it's motor vehicle accidents, what can we do to prevent accidents? Making sure these patients are wearing their seatbelt, making sure they're not driving under the influence, making sure they're driving within the speed limits, being cognizant of that. If it's occupational hazards, are they wearing their safety helmets? Are they adhering to OSHA standards? Making sure our kids are in their car seats and they're where they need to be. Are they in the back? It's not necessarily appropriate for our younger kids to be up front in the front seats. And then home safety to prevent falls with our older patients, right? All of those things that we talk about in the environment with our older patients to prevent falls, slip-resistant rugs, making sure they've got handrails on their stairs, making sure they've got slip-resistant kind of pads in their showers, handrails, rails in their bathroom, right around their toilet when they're getting up. Good lighting. So some of the other things that we can consider in the acute phase, we talked about maintaining cerebral perfusion. We want to do our best to maintain adequate blood flow, oxygenation, glucose perfusion to the patient's brain, and we want to prevent any secondary cerebral ischemia. So we're monitoring for changes in their neurostatus. We said the best way we can do this is through their GCS, okay? Notifying the healthcare provider of even subtle, minute changes because they could mean a lot. So with the patient and the family, right, because they could be scared, and if there's going to be mental status changes, neuro changes, they could be fearful. So we need to stay with the family, comfort them, reassure them, be calm, gentle. So some other things, the factors to focus on related to increased pressure. If these patients are having oculomotor optic problems, they're at they have the diplopia, they have the ptosis, the loss of corneal reflex. We want to be monitoring their eye, making sure they don't develop any corneal abrasions, lacerations. So eye drops, compresses. We actually might consider patching this eye if they can't blink and if they can't keep their eye open. Okay. Hyperthermia related to the hypothalamus being affected. We want to make sure that we're keeping their body temperature down naturally so that we can prevent shivering, because shivering can lead to increased metabolites that can increase our acidosis. So we need to make sure that we are keeping their body temperature where they need to. We can use acetaminophen. We can use cooling blankets. We can also use sedatives like Demerol to kind of keep them from shivering. So some other things to consider if we suspect the patient has a cerebrospinal fluid leakage. We want to keep the head of the bed elevated, and we don't want these patients moving around a lot. We want the dura layer or the tear in the dura to heal, to seal, and so we need to keep their head of the bed somewhat up, and we need to make sure they're not doing tons of moving. So sometimes we can kind of keep this loose collection pad under their nose if they've got rhinorrhea. Because there is a breach in the meninges in the skull fracture, they're at increased risk for infection, meningitis, encephalitis. We want to make sure that we're not putting anything up their nose. So no nasogastric tube, no feeding tube, no nasopharyngeal or nasotracheal suctioning. And then sneezing or blowing their nose, we want to do our best to minimize this, because not only it can increase more release of their cerebral spinal fluid, but it also can increase their intracranial pressure. All right, so a lot of the care of your patient can be the same that we can assume with our patients with strokes, maybe a little bit with our spinal cord injuries. So our concerns with bladder and bowel function in the acute stages, where they are when they're rehabbing, skin care, infection prevention, and considering antiemetics in some of these patients who are having nausea, vomiting. And we're also considering with some of the antiemetics that we're making sure we're using some of the antiemetics that aren't necessarily causing increased confusion, depressed level of consciousness. So we're going to consider analgesics for headaches. Some of the best medications with your head trauma neuro patients is fentanyl. If these patients have to go in for surgery to immediately have kind of a burr hole craniotomy, craniectomy, if these patients are incapacitated and if they're by themselves, we're going to err on the side of caution and they're going to be going in based on emergency preface. But if these patients come in and they can't make their decisions and they've got family there, the family is going to need to give informed consent. So it could be a really stressful situation for the family. We're going to be doing a lot of education, reassurance, and support to help the family cope. So in the rehab phase, a lot of the same things that we're concerned about with strokes and with our spinal cord injuries. Existing motor and sensory deficits, residual deficits, communication issues. So how can we help with communication issues? The same things that we talked about with strokes. Memory and intellectual functioning. Nutrition. Although we said we're minimizing NG insertion with some skull fractures, early nutrition is something that we need to be aware of and that we need to consider as well to help with recovery improvement. VTE prophylaxis, if it's appropriate and if we can. These patients are at increased risk for VTE. And bowel and bladder management, the same way that we would consider with spinal cord injuries and strokes. So weeks to years even after the traumatic head injury, these patients are at risk for seizures. Okay? And so we have to consider whether these patients are going home on anticonvulsants or if they're going to newly start them on anticonvulsants. They're always monitoring for seizure disorders. There's going to be a lot of mental and emotional difficulties. Like we said, some of these patients will come home, their personalities will be completely different. They might be impulsive, a little bit more reactive, more emotional outburst. Okay? These patients, they might find it difficult to hold down a job or maintain a relationship with somebody. As a result, these family members have to be supportive and they have to be aware. And there's going to be specific activities that they shouldn't be participating in. Alcohol use, probably sports, ATV, motor vehicles, operating guns. There's just some things that they shouldn't be doing, in the recovery period, in the rehab, if there's been some changes to their mental, emotional stability and intellectual functioning. So with these patients, obviously, again, to bring it home, we want to maintain normal cerebral perfusion pressure. And this is normally by maintaining their blood pressure, maintaining normal fluid volume status, keeping their blood pressure up without increasing ICP. So we want to do our best to minimize any type of cognitive, motor, and sensory impairments. We want to achieve those things. We don't want them to have infection. We want to minimize and maintain their hypothermia and good pain control.